So we'll start with the most common visual disorders and then move to auditory disorders, which there's only really a handful that we're covering. So a hortulum or a stye on the upper eyelid, it's caused by a staph infection, and it's actually an inflammatory reaction of that sebaceous gland. Very common, perhaps you've had one of these, very painful, tender. So treatment would be a warm compress. It may require either an antibiotic, ophthalmic medication, or a corticosteroid. So blepharitis is a bacterial infection, usually with staph of the eyelid. All I can describe this as is just very goopy. I've had clients with blepharitis and they just have a lot of drainage continuously, redness. Treatment would be to cleanse with a baby shampoo, always one eye at a time from inner to out using different cloths, and then an antibiotic ophthalmic medication. And some clients have chronic blepharitis. So conjunctivitis, very common eye disorder. It can be infection or inflammation. The most common would be a bacterial infection known as pink eye, bacterial conjunctivitis. It's usually with a Staph aureus. The client would have redness, crusty drainage, itching. Treatment would be teaching good hand washing, an antibiotic ophthalmic drug for 24 hours, and teaching about preventing the transmission because it could be spread very easily to someone else or from one eye to the other. Viral conjunctivitis, it really just has to run its course. And again, they usually don't test for sure to find out if it's bacterial or viral. They would just kind of go ahead and treat, but the viral will resolve will resolve on its own. Trachoma is actually a leading cause of blindness in other countries. It's spread by hands and flies and is a type of pretty severe conjunctivitis, again, that can cause blindness. Adult inclusion conjunctivitis is related to a sexually transmitted disease infection. So treatment would be antibiotic therapy. There's also allergic conjunctivitis, which treatment would be antihistamine and artificial tears. So retinopathy, we did talk about this with diabetes and then also hypertension. So diabetic retinopathy and hypertensive retinopathy. It's really due to that microvascular damage to the blood flow to the retina. With the diabetic retinopathy, there's two different kinds. The non-proliferative, which is most common, and that has little microaneurysms that affect the capillaries and cause retinal swelling, ruptures, hemorrhaging. The proliferative, which is least common, causes the new form of collateral circulation, and these new capillaries are weak and they're fragile and they leak and they cause edema to the retina. So both of them can cause irreversible vision loss. The main goal of treatment is to have good blood sugar control and good blood pressure control. There are some new corticosteroid injection procedures that are being done to help improve this, but the main focus would be good blood pressure, good blood sugar. So retinal detachment, make sure you star this one. This is an ocular emergency. So this is definitely one to know about. And the interesting thing with this is there's no pain. So you want to be able to pick up on this early. So some common symptoms would be light flashes, floaters, or rings. If you have a client complaining of seeing a cobweb or a hairnet in their visual field, a curtain coming across their field, all of these would be a red flag to kind of jump out at you and say, ocular emergency, they need emergent treatment. Some risk factors would be aging, any sort of trauma. So let's say you're interested in being a school nurse and a child has an injury in gym class and comes in with some of these symptoms. After cataract surgery, or if you have a history of having a retinal detachment, you're at a higher risk for having another one, or family history. So surgical intervention for retinal detachment, the top two here are pretty common: laser photocoagulation or cryopraxy. These are both either with laser or freezing, are used to seal breaks, retinal breaks. So those are common. Scleral buckling is actually a band or a belt that goes around the extraocular the eye that causes the sclera to buckle inward, and that can reattach the retina. Vitrectomy is actually surgical removal of some of the vitreous, which relieves tension on the retina, and it may be used in combination with this pneumatic retinopexy, which is actually the injection of a gas bubble to reattach the retina. So all very interesting procedures. Many are done as an outpatient. Activity would be, post-procedure activity would be important to minimize anything that would increase intraocular pressure. So macular degeneration, again, this occurs with aging. It's affecting the macula, that central vision. Family history does increase your risk. Also smoking. There's two forms of this as well. So the dry, which is more common, the non-exudative, it's really caused by the atrophy of the macular cells. And then there's the wet or the exudative, which is more severe and rapid, and that's really involving abnormal blood vessels to the macula. Treatment for macular degeneration, nutrition, so vitamin therapy, so an Ocuvite, which has increased vitamin C, vitamin E, zinc, lutein, smoking cessation, monitoring the vision with that Amsler grid that we talked about with assessment. And there are some newer monoclonal antibody injections that can help slow the progression. But there's very little aggressive treatment that's really going to improve. Clients may need large print, magnifying glasses, increased lighting, all of those types of interventions. So enucleation or eye removal, this would be performed if a client had a painful blind eye. It usually takes about 6 weeks for the wound to actually heal. You may be administering antibiotic drops, a pressure dressing, monitoring for bleeding. A permanent prosthesis is usually custom made, and they can really match the other eye, can actually have it move with the other eye, so they've really made quite a few advances with the prosthetic eye. Care, it would be lifelong for this prosthetic eye. You'd want to make sure you teach your patient to wash their hands, to wash the eye. It does have to be removed, and the client would have to perform eye care. It can vary. It might be every so many days. I know years ago it was every night, like a part of PM care, but again, many advances have really been made with the ocular prosthetic eye, but you would want to be aware of the specific instructions for that prosthesis. So cataracts is a very common eye disorder, especially with aging. So we'll go over the risk factors, symptoms, surgery, and patient teaching. So a cataract is involving the lens. It's an opacity within the lens. You can have a cataract in one eye or both eyes. The cataract removal is an outpatient procedure, and it's one of the most common surgical procedures in the US. Some of you that took 102, maybe this was one of your surgery observation days at an outpatient eye center. So aging is definitely a risk factor. So over the age of 40, your risk starts increasing for development of a cataract. By age 80, 50% of individuals will have a cataract, so it's a pretty high percentage. Some other risk factors would be trauma. Maternal rubella can cause a congenital cataract. UV light exposure, so that's an important patient teaching piece about proper eyewear. Long-term corticosteroid use, which we talked about. And ocular inflammation. Also diabetes. Clients that are diabetic have cataracts at an earlier age. So decrease in vision and blurring would be common clinical manifestations of a cataract. Also abnormal color perception. Glaring of vision, which causes a light scatter on the lens, and that can be worse at night. So if your client starts complaining of a really difficult time driving at night. And a client with a severe cataract may actually have the presence of a white pupil. So remember, this is a opacity within the lens, so it can look like a white pupil. So I actually have some video links that I'm going to post on Blackboard, so definitely check those out. These images are from the National Eye Institute, showing you how someone with cataracts, how their vision might be impacted. So these would all be diagnostic studies, that thorough H&P, measuring acuity with the Snellen chart, visualization of the eye with an ophthalmoscope, using high intensity light source, so that slit lamp microscope to really be able to look at the lens, and then glare testing to assess for light scatter. So a client might have a small cataract for years before they actually require surgery. So increasing the light, using magnifying glasses, readers, increasing your eye prescription might all be measures to help with your cataract prior to having surgery. Maybe not driving at night. As the cataract increases in size, or the symptoms worsen, that's when you're looking at a cataract removal. So pre-op, you would do a lot of your patient teaching pre-op. So clients are going to need to know how to instill eye drops and safety measures in the home we'll talk about. So pre-op, clients would be on a non-steroidal anti-inflammatory eye drop. They also would be receiving a dilating eye drop, so a mydriatic or a cycloplegic, possibly a local anesthetic. Clients may have light sensitivity, so they may need dark glasses. Anxiety, anti-anxiety medication. So patients are awake for the cataract extraction. An operating microscope is used. So the most common would be this phacoemulsification. It uses ultrasound vibrations to break up the cataract and then suction out the lens, and then an intraocular lens is placed in place. A lot of times sutures are not required unless it's a very large cataract. So an extracapsular cataract extraction is used for large cataracts, and sutures are required and recovery is slower. So again, clients really need to have a family member, friend, neighbor drive them to and from the procedure. Hopefully preoperatively you're able to teach the client how to administer eye drops, and anyone that's had a cataract removal or perhaps assisted a parent have this outpatient procedure done, a lot of patients will report those first few days that remembering the eye drops, and because they're frequently throughout the day and you're usually on more than one, is kind of like a full-time job. So that's important that you have written instructions, that the client knows how many drops, which eye, when to do them. When you're administering more than one eye drop, you do want to wait at least 5 minutes in between. Activity is really important. You want to minimize anything that's going to increase intraocular pressure. So you want to teach your patients to bend at the knees, no coughing, avoid coughing. Hopefully constipation was addressed preoperatively, because you really don't want any straining or blowing your nose or lifting. So any measures to kind of minimize increased intraocular pressure. Follow-up is super important, so you really want to stress that. Visual acuity will be measured pre-op, post-op, and at each follow-up appointment, so that's an important piece. Some clients may have an eye shield, or so there's some safety concerns in the home, and again, that might be dependent on the surgeon. So I'm going to let you read through the next 7 slides on the nursing process related to cataract. I did cover this information on the slides that we just went through. So I do encourage you to watch the video that I posted on Blackboard on glaucoma. I think it does a great job comparing your eye to a sink and a drainage system, and that's really what we're concerned about with glaucoma, is increased pressure. So there's either too much drainage in the eye, so too much aqueous humor, or there's a problem with the outflow through that canal of Schlemm and that trabecular meshwork. So similar to a drainage pipe. So definitely check that out. So again, glaucoma is a disorder that can cause blindness, and it's all about pressure, and that increased pressure damages the optic nerve. A lot of times a client can go for a number of years without any symptoms at all until they start to have subtle symptoms with that tunnel vision, that peripheral visual field loss, and at that point, the damage is irreversible. Actually, the same uncle that I shared has significant hearing loss. He also has very advanced glaucoma. So I feel very bad for him because he can't really see that well, and then also the loss of hearing. So he's very isolated and really definitely impacts social activities, family gatherings, time with his wife, just an overall, just on daily quality of life. So risk factors are increased age and African Americans. It's more common. Family history. Glaucoma is viewed as preventable with regular eye exams, which really should start at age 40, if not earlier. There's two different kinds of glaucoma. So primary open-angle glaucoma, which is the most common. This is really due to, again, increased pressure in the eye due to either increased aqueous humor or an issue with the drainage of the aqueous humor. This is the type of glaucoma that develops very slow over a period of years. A lot of times there's no symptoms until the client starts to have that tunnel vision, like I mentioned. These clients usually have pretty significant symptoms, severe pain, nausea, vomiting, visual symptoms. So this is a more severe rapid onset of glaucoma, the primary angle closure glaucoma. This, again, you can have this as a chronic condition or as an emergent condition. Increased age and prolonged pupil dilation are two factors that can cause this. So we talked about the normal intraocular pressure of 10 to 21 millimeters of mercury. With open-angle glaucoma, you're going to see elevated levels, and then with the acute angle closure, extremely elevated levels greater than 50, and again, we're concerned about that irreversible damage to the optic nerve. So these images are also from the National Eye Institute, showing symptoms of vision, how somebody might have changes in their vision with glaucoma, that tunnel vision with the open angle. So visualizing the eye, the pressure measurement, the vision of the retina and the optic nerve would all be diagnostic studies. Open angle glaucoma, clients will be on drug therapy, which does not cure but can help with the elevated pressures. And then the treatment would be a laser trabeculoplasty or a trabeculectomy. And again, that goal of treatment is to stimulate the outflow of the aqueous humor. So with acute angle closure glaucoma, remember the pressures are much, much higher. Clients would be on miotics, ophthalmic medications, which will help lower intraocular pressure. They may also be on an oral or IV osmotic diuretic, so maybe a mannitol, and then they are going to need a surgical procedure to create a new outflow. So a laser peripheral iridotomy or a surgical iridectomy, and that again is creating a new outflow channel through the iris. So I also want to just mention that if a client has a chronic closed angle glaucoma, they will be on lifelong frequent ophthalmic miotic drugs to help keep those pressures under control. There can be a lot of fear with glaucoma because again it can lead to blindness, so providing support and involving caregivers, because clients will have decreased vision, is important. So safety is a concern. Clients are at risk for injury due to the visual acuity deficits. Self-care, pain. Glaucoma can be very painful, that angle closure glaucoma. And again, the eye drops can be almost like a full-time job for glaucoma as well. And any ophthalmic medication can have systemic side effects. So again, one of the most common treatments would be a beta blocker. When we go through the ophthalmic drug PowerPoint, you'll notice that's one of the most common, and it can have systemic effects. So clients perhaps might have hypotension, bradycardia, headaches. The whole goal is to preserve the vision that they have and prevent any further loss of vision. So you really want clients to understand the importance of follow-up and the drug therapy and procedure education. So on one of the first slides I mentioned that it was preventable. So that importance of regular eye exams, that's so important to identify these increased pressures early so that you can prevent permanent vision loss. I'll just let you read through the next 3 slides.